waking up with a pretty major system, that being the lungs. And with the lungs, we'll work forward and we'll look at some of the different segments of the lungs. And after doing that, we will work our way backwards and review the pleura, basically what surrounds them, and the pulmonary cavities, and then also the lymphatics of the mediastinum that immediately surround it and go through that region. I'm working backwards because I just felt like it made the most sense to cover this major system first and then kind of work our way backwards. Excited for you all to join me on this. If you have been enjoying these videos and you haven't subscribed yet, I would love it if you did. If this is your first time, welcome. If you like what you see, please leave a like. It allows other people to see the videos that I'm putting out. So, without further ado, let's get started. Alright, so we are in the lungs. It's got the lungs in situ. The left and right lungs occupy the full volume of the pleural cavity. Note that the left lung is slightly smaller than the right lung due to the asymmetrical position of the heart. Alright, and we can kind of see that here. So the left lung, which is going to be on the right side, is a little bit smaller because it's displaced by the heart. The left lung. Because I'm looking at it from the bottom. From the front, it would be flipped. So we've got the superior lobe on both sides. We've got a horizontal fissure on the right lung, an oblique fissure on the left lung, and an oblique fissure on both lungs, actually. So the right lung is going to have 3 lobes, and the left lung is going to have 2 lobes. And then we've got an inferior lobe on both sides. Here's the esophagus and the descending aorta, just to orient ourselves, and then the mediastinum that contains the heart, running right through the middle. Alright, and here are the lungs retracted back, just to show us what other major structures are in the area. And really, key structures here that I want to highlight are those pulmonary arteries, because they're carrying deoxygenated blood. Again, kind of backwards. Normally arteries carry oxygenated blood, but these pulmonary arteries are carrying deoxygenated blood to the lungs to be oxygenated and then carried out and back to the heart and in through the system, through the body. Here's another vantage point of that right lung. So again, it's going to be on the left-hand side because it's flipped. So we've got a superior lobe, and then I don't know if we're going to be able to see the fissures. Here we go. So here's the horizontal fissure that we saw on this chart here. Here's the middle lobe, and then here's the oblique fissure on the side. And then we've got the oblique fissure on this side, so mirrored in that regard. Inferior lobes on both sides as well. And you can see they pretty much sit right on top of the diaphragm, which kind of highlights the relationship between the diaphragm and breathing that we have talked about and will likely talk about more in the future. We're going to talk about the different pleura and when we backtrack a little bit, so I'm not going to get too far into those right now. But really wanted to highlight those vascular structures. I mean, we can see the aortic arch here. This is where the heart would be right here. And then we've got the superior vena cava. The inferior vena cava would go through this opening right here. And then we've got the left subclavian artery and vein, and the left brachiocephalic vein, the brachiocephalic trunk, or the arterial trunk. And I think that's really everything that I wanted to highlight on this one. Of course, the diaphragm features that we've talked about before, with the central tendon right here being a major attachment point for multiple structures. Let's get into the gross anatomy of the lungs over here. The oblique and horizontal fissures divide the right lung into 3 lobes, superior, middle, and inferior. The oblique fissure divides the left lung into 2 lobes, superior and inferior. So, what we saw over here, just in a different orientation. The apex of each lung extends into the root of the neck. The hilum is at the location at which the bronchi and the neurovascular inserts into the costomediastinal recess, both sides. Here's the costal surface, and here's the costal surface on each lung. And then here's the differentiator between the right and left lung being the middle lobe, and that horizontal fissure which creates the middle lobe. Here's the oblique fissure, which we have on both sides, and then the inferior lobe. And then here's a little structure on the left lung called the lingula. The lingula. And then there's an inferior border on both sides that inserts into the costodiaphragmatic recess, which is basically this border right here, which makes sense, this recess. It's called that because of the costo verbs, the ribs, and then the diaphragm right here, so costodiaphragmatic recess. And then there's going to be a costomediastinal recess, which is a little bit more difficult to ascertain because the lungs are retracted. We'll see if we can find it on a different picture. Alright, here is the lung, basically flipped over. It's a medial view on each side. Here's the apex again, superior lobe, but here let's get into the specifics of this portion right here. And those key features are going to be the superior lobar bronchus, the inferior and middle lobar bronchi, common origin. So this is the attachment point for your airways, for the air that's coming in. Here is the branches of the right pulmonary artery, and they're blue because, again, even though it's an artery, it's carrying deoxygenated blood to the lungs to receive air and then go back to the heart and be carried through the body. And then the branches of the right pulmonary veins. So these veins are carrying that blood, that now oxygenated blood, from the lungs back to the heart. So this is the rare exception. You know, normally when you hear arteries, the way I always remembered it, in a blanket form was an artery equals A away from the heart. Deoxygenated blood away from the heart. This is an instant where the script is flipped because of the way that the interchange has to take place so that the blood could be oxygenated so that you and I can live and move and breathe. And here's a structure that we haven't been able to see yet, this pulmonary ligament, which is basically another attachment point for the lungs. Here are those recesses that we already talked about. And then the cardiac compression, that's where the heart, the receiving area for the heart, kind of a sulcus for the heart. And it's probably classified more as an impression because with the expansion and the contraction of the heart, this lung tissue has to be pliable, which thankfully it is. Now let's look over at the left lung and see if there's any major differences in the attachments. So again, we've got the superior and inferior lobar bronchi, the branches of the left pulmonary artery, the branches of the left pulmonary veins, another portion of the cardiac compression, which again, remember that the left lung is smaller than the right lung because the heart is more positioned to this side. So there's a cardiac compression here, and then you can see I would say relatively clearly that the cardiac compression is larger over here. And then here's the cardiac notch as well. And there's that lingula. I think that's, Here are the bronchopulmonary segments of the lungs. The lung lobes are divided into bronchopulmonary segments, the smallest resectable portion of the lung, each supplied by a tertiary or third segmental bronchus. Note, these subdivisions are not defined by surface boundaries, but by origin. Good to know. Alright, so here's the trachea and the bronchial tree, and it's showing us the relationship between, and it's thankfully color-coded. So this, for the right lung, the upper right is going to go to the superior, the apex up here. 2, 2, 3, 6 we can't see, but 8 we can see over here. And then there's also a 7, a 9, and a 10. Yeah, we're going to see those other aspects over here. We'll match them back up over here. In the left lung, 1 to 1, 2 to 2, 3 to 3, 4 to 4, 5 to 5. 6 we can't see, but 7 and 8 we can see on this left lung. I'll keep going over here and then I'll get into the segmental architecture outline down here. So we're on the inside or the medial portion of the right lung. So let's highlight the ones that we weren't able to see. So 1 is going to go to 1, 2 will go to 2, this inner portion, 3 to 3, 4, let's see, where are you? Looks like 4 is only an anterior portion, but we can now see 6, which we couldn't see before, which is here. We couldn't see 7, which is on the very inside here. We have 5, and then we have 8, and 9, and the 9 was there, and then 10 is there. Looks like they actually got their colors flipped. That's funny. That's okay. We'll give them a pass. Posterior view, relatively straightforward. Pretty much just a different orientation on the connections that we've already highlighted. And then here's the lateral view. Left lung, not really a whole lot different. We do have 5 and 6 next to each other on this side. That's a little different. And then, yeah, I would say that's the biggest primary difference between the medial portions, is that 4 and 5 both contribute over here, but 6 is pretty much the same, 2 is the same, 3 is pretty much the same. So, and then it looks like maybe, so 7 and 8 both have some activity here, yeah. They're kind of rolled together. And then 9 and 10, yeah. So, despite the multiple lobes, the contribution is largely the preserve part of a segment, you can know where that contribution more or less ends based on your understanding of the contribution from the bronchial tree. So, as shown here in this example, the segmentectomy, or a wedge resection, is the removal of one or more segments. So here they're taking segment 1 of the right lung, leaving 2 and beyond below it. And then on the back, we would probably see some removal of segment 2 based on this. A partial removal of segment 2. A lobectomy, so the removal of an entire lobe. So just taking out either this lobe here, or maybe probably this lobe here. It's unlikely that they would take out the middle lobe. On the left lung, you could take out the entire upper portion or the lower portion. And then a pneumonectomy. The removal of an entire lung. Definitely not ideal, but they'll take it right off. Alright, that's going to end our forward progression. Now let's backtrack a little bit. For you fans of page turning, here you go. So we've got the pleura, subdivisions, recesses, and innervation. The pleura and its divisions. The interior thoracic wall and costal portion of the parietal pleura have been removed to show the lungs in situ. And as we work our way back, we'll get more into those pleura. But we can see the superior lobe, the middle lobe, and the inferior lobe, so we know automatically this is the right lung. I know that's probably straightforward, but the more we cover it, the more it gets ingrained. Right has 3, left has 2. So we've got the parietal pleura, the mediastinal portion, the costal portion, which makes sense. Mediastinum's here. Costal, the ribs are here. The lung with visceral pleura. Here's the pericardium, kind of tucked in here. Here's the more of the mediastinal portion of the parietal pleura. And there's the diaphragmatic portion of the parietal pleura. Clinical box. Another clinical box. Another clinical box. 10.1, percutaneous liver biopsy. Percutaneous liver biopsy is usually performed 2 to 3 centimeters superior to the inferior border of the liver at the right mid-axillary line. So here's your axillary line, midway down. 2 to 3 centimeters superior of the inferior border of the liver. So the inferior border of the liver is probably about right here, which I think they're going to talk about. The biopsy needle transverses the skin, the thoracic wall, the costal parietal pleura, the costodiaphragmatic recess, which is where the lungs come into, so that recess right here. The diaphragm, and then enters the liver and the abdominal cavity. The lower margin of the right lung rarely descends into the costodiaphragmatic recess during quiet inspiration, and the costal and diaphragmatic parietal pleura are opposed by surface tension forces. Before inserting the biopsy needle, the physician will ask the patient to exhale and hold his or her breath. This increases the opposition of the costal and diaphragmatic pleura, more tightly closing the costodiaphragmatic recess, and further decreasing the risk of pneumothorax. Pneumothorax is a medical term for a collapsed lung. So if that needle were to go in and puncture the lung could collapse. Obviously, we want to avoid that. The introduction of air in the inner of pleural space when the biopsy needle is inserted. Pneumothorax, if severe, can produce lung collapse. Okay, so if you want to biopsy the liver, this is kind of a shortcut without having to make it more painful for the patient. Costomediastinal and costodiaphragmatic recesses. On the left side of the thorax, an examiner's fingertips are placed in the costomediastinal and costodiaphragmatic recesses. These recesses are formed by the acute reflection of the costal part of the parietal pleura onto the fibrous pericardium as the mediastinal pleura, costomedial portion, or diaphragmatic as diaphragmatic portion, diaphragmatic pleura, or costodiaphragmatic. So basically it's just indicating different ways that you can maneuver these pleura to see different anatomical features. That's the main takeaway. So here is the costomediastinal recess. Here's the costodiaphragmatic recess that the lungs slide into. This is the medial portion that the lungs slide into on both sides. And here's the inferior portion, the costodiaphragmatic recess that the lungs slide into posteriorly. And then it's just showing anatomically that there's the pericardiacophrenic arteries, veins, and nerves going through here. And there's the pericardium. Now, innervation of the pleura. The costal and cervical portions in the periphery of the diaphragmatic portion of the parietal pleura are innervated by the intercostal nerves. The mediastinal and central portions of the diaphragmatic pleura are innervated by the phrenic nerves. The visceral pleura covering the lung itself receives its innervation from the autonomic nervous system. So, outer portion here, intercostal nerves, inner portion, parietal pleura, innermost portion, the visceral pleura, innervated by the autonomic nerves. There you go. And these nerves are what can tell you if you have what's a condition called pleurisy, which is if you have a painful inflammation of any of these pleura. It's no good. I promise you that. Very painful. Alright. Backtracking one step further, we've got the pulmonary cavities. The paired pulmonary cavities contain the left and right lungs. They are completely separated from each other by the mediastinum and are under negative atmospheric pressure. The left pulmonary cavity is slightly smaller than the right, especially anteriorly due to the asymmetrical position of the heart in the mediastinum, which we already talked about. And there's the greater mass on the left. This causes a shift of some of the boundaries of the parietal pleura and the lung on the left side at the level of the heart, as reflected in the difference in the thoracic landmarks found at the intersection of the anterior border of the pulmonary cavities with certain reference lines on the left and the right. So it says the upper red dot on each reference line is the inferior boundary of the lung. Here, 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 and here. And the lower blue dot is the inferior boundary of the pulmonary cavity. Here, 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 and here. And then for reference or orientation, we have the midclavicular line and the sternal line. On the back, we have the paravertebral line and the scapular line. And then using those same lines, we have the mid-axillary line, which we just talked about a moment ago when it came to the liver biopsy, the mid-axillary line. So that upper boundary is here, and the lower boundary is here. And then here's that costodiaphragmatic recess. Here and here. And the lower border here, or upper border here, lower border here. And then it says pulmonary recess, coronal section. Yeah, we already talked about this because we talked about the liver biopsy. And then here's a transverse section, inferior view. So you can see here we're looking up and in. We've got the reflection of the costal pleura onto the pericardium, forming the costo-mediastinal recess. So the fibrous on the outside and the serous pericardium surrounding the heart, and then the parietal pleura mediastinal portion, left and right lungs. We've already talked about that in depth. If there's anything else that's worth noting here, everything else is pretty straightforward from what we've talked about in previous videos, which is a good thing. That means that we're getting content that we have reviewed before, and hopefully is sticking, right? There's that recess, costo-mediastinal recess. And then there's the oblique fissure on both sides. I'm looking to see if there's anything different that we haven't talked about. I don't think there is. And then the lymphatics we can go through here pretty quickly. The superior phrenic lymph nodes drain lymph from the diaphragm, pericardium, lower esophagus, lung, and liver into the bronchomediastinal trunk. The inferior phrenic lymph nodes found in the abdomen collect lymph from the diaphragm and lower lobes of the lungs and convey it to the lumbar trunk. Note, the pericardium may also drain superiorly to the brachiocephalic lymph nodes. Sorry about that. Got caught up on that one. So here's a thoracic duct. So that's a collection point. Here's paratracheal lymphatics, the intercostal lymphatics, the prevertebral lymphatics, superior phrenic. So all of these are taking waste products from blood and then assisting with their disposal, because more often than not, a lot of the lymphatics end up being processed and removed in urine or waste products. Anything that's not supposed to be there. Okay, so we got the tracheobronchal lymphatics, the brachiocephalic lymphatics. Lymphatic drainage of the heart. A unique crossed drainage pattern exists. Lymph from the left atrium and ventricle drains to the right venous junction, and then lymph from the right atrium and ventricle drains to the left venous junction. Hence the cross terminology. So there's the crossing over. There's the crossing over. There's the bronchopulmonary lymphatics in the back of the heart. You can see it again from this view. Yeah, pretty straightforward. And then the paraesophageal nodes drain the esophagus. Lymphatic drainage of the cervical part of the esophagus is primarily cranial to the deep cervical nose and then to the jugular trunk. The thoracic part of the esophagus drains to the bronchomediastinal trunks in two parts. The upper half drains cranially, and the lower half drains inferiorly via the superior phrenic lymph nodes. The bronchopulmonary and paratracheal nodes will drain lymph from the lungs, bronchi, and trachea into the bronchomediastinal trunk. So there's the paraesophageal and the paratracheal again. More of the paraesophageal and the cardiac lymphatic ring. Let's see. And then the bronchopulmonary again on the back of the heart. Another view of the paraesophageal here. So yeah, I think that about puts a bow on that portion. And with that, we'll bring this video to a close, but let's see what we've got to look forward to next time. So we did the bronchopulmonary segments. Here's the trachea and the bronchial tree, and I think that's where we'll pick up next time. So, as always, thank you for watching. If this is your first time here, welcome. So glad you're here. If you like what you see, please like and subscribe. Allows people like me to keep making content for people who hopefully enjoy it like you. So, until next time, I will see you all soon. We'll be picking up, I more Spanish review. So, whether you like the Spanish or the anatomy or the Bible reading, hopefully if I can find something for you. And if not, feel free to always leave a comment. I'm always open to new ideas. But until next time, I'll see you all soon.